Hi, everyone. We're going to wait just a couple minutes to allow folks to join the session. While we wait, feel free to use the chat to say hello to your fellow attendees and let us know where you're from.
We've got Fargo, North Dakota in the house, Long Island in the house. I see Bella's here. Hi, Bella. Iowa, Portland, Washington State. Oh, I like sunny Portland.
Zero,
Sunny
Michigan.
Port, sub-zero, sub-freezing Michigan, Montana. We got
Awesome. I love
Oakland,
this.
California, Davis, California. I see Nashville.
Oh yeah.
Welcome, Glenda. You got Virginia Beach. Oh, it has to be sunny San Diego. Cold Maine. Bosnia. Hello from
Huh?
Bosnia. Massachusetts. Oklahoma. Well, we've got 97 people on, everybody. It's great.
Okay. Why don't we get
Edmonton.
started then? Hello, everyone. Thank you for joining the Marfan Foundation and its divisions for our webinar titled Beyond Direct to Consumer, Choosing the Right Genetic Testing for Marfan, LDS, VEDS, Stickler, and Related Conditions. I'm Lauren May, Senior VP of Research at the Marfan Foundation. I'm joined by my colleagues, Dr. Josephine Grima, Chief Science Officer, and Stephanie Amdra-Clark, Director of our Help and Resource Center.
Hi
Before
guys.
we, oh, Before we kick off our presentation, Helene Baruch, the Marfan Foundation's Deputy Executive Officer, would like to say a few words. Helene?
Oh, thank you, Lauren, and welcome everybody. I see we're up to almost 100 people. I just want to shout out and say thank you to Maya for joining us tonight and for her presentation. This is the first session of 3 on genetic testing. So I know Lauren's going to share the next 2, but we are thrilled to be able to have this series and have all of you join us from all over, I'm going to say the world, which we've got Australia, I see, is on here as well. So thank you so much for being on. If you have any questions, I know Lauren's going to go through this, but please put them in the Q&A, not in the chat. And then what we'll do is go through them when we have towards the end with Maya and try to answer as many as we can. And if we can't get to them, we will be sure to get to them in some way to you. So with that said, I'm going to kick it back over to Lauren.
Thanks, Helene. And I'm just going to echo what Helene mentioned. For this webinar, we will use Zoom's Q&A functionality to field any questions you may have about today's presentation. Please select the Q&A tab on your screen to submit your questions anytime during the webinar, and we'll cover as many as possible at the end of the session. Also, this webinar is being recorded and will be posted to the Marfan Foundation's YouTube channel in the next several days. I am honored to introduce our speaker for today. Maya Brown-Zimmerman is the cardiogenetic counselor at Norton Children's Hospital, where she provides genetics-related services to children and adults, including in the Cardiovascular Connective Tissue Disorders Clinic. She's been an active member of the Marfan Foundation community for over 20 years and currently serves as an advisor to both the Board of Directors and the Professional Advisory Board. She lives in Louisville, Kentucky with her husband, 4 children, and 3 cats. Maya, thank you so much for being with us today. I have to say there has been so much excitement around this webinar, so it's wonderful that we're finally here. The floor is yours.
Thank you so much. All right, I'm gonna go ahead and share my screen. It shows the title screen, right?
It's perfect.
Okay, great. I'm so excited to speak with you guys tonight about direct-to-consumer testing and kind of beyond that, how to choose the appropriate genetic testing for Marfan, Loeys Dietz, VEDS, Stickler, and related conditions. So tonight we're going to talk first some kind of genetics 101, and then we'll talk about the direct-to-consumer testing landscape. And I will say that this is going to be kind of through the USA lens in terms of companies that we're talking about and clinical genetic testing. So kind of how that's different from direct to consumer, what the right tests are, and then how to access tests. And again, talking about accessing testing will be through kind of a United States lens. For disclosures, I did not have a relationship with any of the companies that are mentioned in tonight's webinar. Okay, so first, let's make sure that we are all on the same page about the technology or the terminology that we're going to be using. So I'm going to explain this the way that I explain it in clinic. And my hope is that you can use this analogy to talk with your own kids about genetics. So have you ever played with Legos? If you have, you know that in a Lego kit, you have the box, you have the instruction manual, and then you have the blocks. So our genes are the instruction manual. They tell our body how to build itself. The Lego blocks are the proteins that kind of make up our body. And then chromosomes are the box. So they're the structures that hold our genetic information. A change in the instruction manual can lead to a change in what proteins, or Legos, are used. So when we do genetic testing, we're looking for spelling changes that would tell your body to build itself differently. Just like you can see here with the Starfighter Star Wars ship, in the changed copy, one of those Legos is switched out for a red piece. It's still a spaceship, it's still gonna fly, but probably not as efficiently as it would if it had used the original kind of intended blocks. Now, in terms of mechanisms for genetic conditions, this is not exhaustive, but for the purposes of today's conversation, these are the mechanisms that we're going to focus on. So we have chromosomal changes that could cause aortic disease. So changes in the amount of that box. And then with monogenic, mono means one. Monogenic conditions are caused by a change in a single gene. And then with polygenic, poly means many. Polygenic conditions are caused by small changes in many genes, plus environmental factors. And at the bottom, we have syndromic conditions, and that means that they affect multiple body systems. And then non-syndromic conditions affect one body system. So in the context of aortic conditions or aortopathies, these are some examples. A chromosomal condition would be 7q11.2 duplication syndrome. This condition can cause autism, it can cause intellectual disability, and can also cause aortic aneurysms. Monogenic syndromic conditions, that's where you have Marfan, Loeys, Dietz, and VEDS, right? These cause aneurysms, but they also can impact the way that our body looks or other body systems. Some examples of monogenic non-syndromic genes are ACTA2 and MYH11. These impact the cardiovascular system, but not other systems. And then with polygenic, examples could be an isolated abdominal aortic aneurysm, or some of the syndromic features of Marfan, et cetera, like spontaneous pneumothorax or cleft palate. So obviously, we can see abdominal aortic aneurysms in Marfan and related conditions. But if I'm taking your family history and the only aneurysm in the family is an abdominal aortic aneurysm that your 60-year-old uncle has, I'm going to be thinking more about polygenic as a possibility. Being male, smoking, untreated high blood pressure are all environmental factors that can contribute towards abdominal aortic aneurysms. And then with spontaneous pneumothorax, so that spontaneous collapsed lung, yes, some of the conditions that we're talking about can cause those, but so can being a tall, thin, young adult male. So part of what we're doing in genetics is looking at all the possible causes, both monogenic and polygenic. Other important vocabulary, genetic changes are called variants, and a single nucleotide polymorphism, or SNP, is a variant that is seen in at least 1% of the general population, which, as far as genetics goes, means that that's a common change. SNPs don't typically cause disease, but they likely do play a role in polygenic risk. So again, in those conditions where there are lots of small changes, so multiple SNPs together plus environmental factors. We have 3 different classifications for variants. Genetic testing is not always as straightforward as yes or no. These variant classifications are benign, meaning harmless, pathogenic, meaning diagnosis causing, and uncertain. You may have seen on a test report also the terminology likely benign or likely pathogenic. Those are the same things. So likely benign and benign, we treat the same. Likely pathogenic and pathogenic, we treat the same. I'm going to use the sentence, I have a gray bat, as an example of kind of these 3 variant classifications. So a benign change would have, I have a gray bat becomes, I have a gray bat. So if you look, there's a letter swapped here, A for E, but there are 2 ways to spell gray, G-R-A-Y or G-R-E-Y. So swapping that A for an E doesn't actually change the sentence at all. We all have harmless changes in our genetic material that just make us unique, but they don't impact the function of the gene or the protein. So those changes are even included in the genes that are related to aortic conditions or to Stickler. Now, for an uncertain example, I have a gray bat becomes I have a green bat. Are we talking about a baseball bat or are we talking about the animal? Baseball bats can be green. I have a neon green one in my garage right now, but bats that fly in the sky are definitely not green. So we need more information to know whether this change affects the meaning of the sentence or not. An uncertain result is not a diagnosis. Statistically, most uncertain results get reclassified as being benign or harmless once the lab gets more information. And so in genetics, the default is to treat these as a negative result and instead treat a person based on their symptoms. Now, sometimes there's follow-up testing that a provider can order that can help with reclassification. And other times we just have to wait on the lab to get more information. That more information might be waiting for other symptomatic or asymptomatic people to test, for that same uncertain variant. It might mean functional studies. It could be research papers being published with someone else that has the same variant. There's a lot of different things that can go into that. And then for pathogenic, I have a gray bat becomes I have an unpronounceable bat. I have a gray bat, or I have a. So there are a lot of different spelling changes that can change the meaning of the sentence, both with letter swaps or extra or missing pieces. When the body's producing the wrong protein or cutting off protein production, it can change the way that the system should be functioning. So now that we have some of those terms down, let's talk about direct-to-consumer or DTC testing. So why is direct-to-consumer testing popular? Well, there are a few reasons. I think for a lot of people, it started off as a tool for genealogy. It can be kind of fun to do the testing and figure out, where in the world your ancestors came from, or as a way to connect with distant relatives. I know I've done it for those things myself. Some people use it because you can avoid reporting results to insurance companies. There is a law called GINA, the Genetic Information Non-Discrimination Act in the US. And that law says that your health insurance cannot discriminate against you for your genetic testing results. So they can't kick you off your insurance, they can't raise your rates, things like that. With the exceptions being if you're active duty military or if you get your health insurance through an employer with less than 15 employees, because those categories have their own rules. It does not apply to what they call luxury insurance. So new life insurance, new long-term disability insurance. Those can ask about anything in your medical record, genetic test results included. So Some people prefer to go the direct-to-consumer route, so they don't need to, have that in their record. Direct-to-consumer testing is also very accessible. You don't need to go through a provider. You can just go online, order a kit, have it sent to your house, and mail it back. Finally, you don't have to meet guidelines. So for some types of genetic testing, there are guidelines in place to determine who can get the testing. So for example, for genetic testing related to cancer, we look to the National Comprehensive Cancer Network, or NCCN, guidelines. These are pretty clear-cut based on the type of cancer, who in the family needs to have had it and at what age. But if you don't meet the guidelines, because say you're adopted and you don't know your family history, insurance may not cover that testing. So some people turn to direct-to-consumer for that reason. But there are real concerns with this method of testing. For starters, there's very little oversight. The government is not controlling these labs to make sure that you're getting what they say that you're getting, that they're doing the testing in any kind of certain way. You don't know for sure what you're getting. They're also reporting SNPs, so those common genetic changes. And they may or may not be useful for polygenic risk. We have some clinical polygenic risk tests available for certain conditions, but direct-to-consumer polygenic risk may not have full coverage of all the risk alleles, and it may not incorporate all aspects of risk. So they may not take into account things like your biological sex, ethnicity, lifestyle, things like that. Additionally, some of the SNPs that they're reporting don't have clinically correlated tests yet, and some SNPs are related to monogenic conditions. So if you do direct-to-consumer testing and it comes back with a SNP in, say, TGFBR1, well, that doesn't cause Loeys-Dietz because SNPs don't cause rare diseases. And it doesn't increase your risk of developing Loeys-Dietz because that's not how Loeys-Dietz works. That's a monogenic condition. So it's just a benign variant. But how are you supposed to know that? And that comes into the lack of interpretation and follow-up care. Now, I've seen in a lot of patient groups where people are learning about a website called ClinVar, and they're suggesting that you use that in order to interpret your own direct-to-consumer results. ClinVar is a great tool. It's a website where labs and researchers can upload variants and their interpretation. Sometimes labs include the evidence that they use for their interpretation, and sometimes they don't. But it's only one tool. So this slide is a little bit hard to read, and I apologize for that. But it's to show that variant interpretation is a complicated process. The American College of Medical Genetics has created this checklist that labs use to apply to each variant to determine its classification. So the red section is criteria for pathogenicity. The green section is benign criteria. And there's some leeway for interpretation between labs. It's not an exact science, much like most things in medicine are not an exact science. But there is education that goes into learning how to do this. And we're not at the point where AI is a substitute for the human interpretation. There's another webinar in this series that's going to focus on variants of uncertain significance. So I'm not going to go into more detail, but just to understand that interpretation is more complex than whether a person's symptoms fit with the condition. And if no professional is interpreting the results, you can have incorrect results. And additionally, there's the concern that if no one's helping you understand the implications, they may not be helping you get appropriate follow-up care for results either. Other concerns include incomplete coverage, which can mean two things. So first, the lab's technology may not have a good depth of coverage. I saw a lab recently that was advertising full genome sequencing for like absurdly cheap, but their depth of coverage was 2 times. I compared that to a report that just came in from one of the labs that I order from, and their mean coverage was over 160 times. So you can imagine that things may get missed with the first lab that's only looking at it twice. Second, there are some direct-to-consumer labs that offer clinical testing, but maybe only for a few things. So I'll give an example of one in a minute. Sometimes the information from these reports is just wrong, maybe in part due to AI. I saw a report recently where the lab said that TGFBR1 causes a condition called hereditary hemorrhagic telangiectasia. It doesn't. And I've heard from colleagues at other places about reports listing pathogenic variants that then on repeat clinical testing are not there. Finally, these are for-profit companies. They don't have to follow HIPAA. Your data can be sold, and it can be difficult to understand what your privacy rights are with some of these companies. Now, 23andMe is a direct-to-consumer lab where you can get some medically accurate results. So they have FDA approval for some specific tests. And for those specific tests, I would consider their results accurate. I will say that the fine print on the 23andMe website does still suggest clinical correlation for some of these, though. They're also clear that they're not reporting full coverage for these conditions. So this means that a positive result is likely to be truly positive, but a negative result may not be truly negative. For example, they have some breast cancer variants that they report related to variants that are more common in the Ashkenazi Jewish population. So if you do the 23andMe test for breast cancer and it comes back positive for one of these variants that's common in the Ashkenazi Jewish population, it's probably an accurate result. But they say on their website, they don't include all of the most common variants related to breast cancer. So if you do their test and it's negative, it's possible that things are being missed. They also have carrier status for 45 conditions. Again, limited variants within those conditions, and they have some pharmacogenomic testing as well. Now, those FDA-approved tests are not the same as uploading your raw data. So if you go uploading your raw data to a third-party website, you're opening yourself up to the same issues with SNPs being reported and lack of interpretation. 23andMe is now offering a new tier of testing for $499, and they say that it's diagnostic testing for Marfan, Loeys, Dietz, and VEDS. I'm unclear from their website whether it's truly full sequencing, or whether they're only reporting variants that have already been reported elsewhere, like in ClinVar. And it's not clear who's interpreting the results and whether uncertain results will be reported. I have reached out to the company a couple of times to get clarification, and I haven't gotten a response. So I can't say that this test is equitable to clinical tests. I can't say that it's not either, just because I don't know the limitations. But if you were going to pursue this route, I would ask some of those questions before doing the test to make sure that you know exactly what you're getting. Now, Invitae is a lab that is a clinically recognized lab. A lot of hospitals use it. And they have a test called the Comprehensive Genetic Risk Panel. This is not technically direct to consumer anymore. They used to let patients just order it through their website, and now a medical provider has to. But it can be any medical provider. So your PCP can order this test. It's $299 cash pay. They don't take insurance for this particular test. It covers 163 genes, a lot of aortopathy genes, although it does not include the type for Loeys Dietz type 6, nor does it include Stickler genes. It includes some cancer risk genes, cardiomyopathy, which is heart muscle conditions, arrhythmia conditions, just a lot of like general health issues are on this panel. Uncertain variants are not included. So if you have an uncertain result, they're not going to report it to you. But if that variant is later reclassified as likely pathogenic, then the lab would send you a new report. So there's no interpretation that has to happen with this test from a doctor. So a PCP may be more comfortable ordering this one than a panel, which we'll talk about those a little bit later, where they would need to interpret uncertain results. Some red flags that, from my opinion, you should consider if you're going to go the direct-to-consumer testing route. One is the use of AI for interpretation. AI is a popular tool. I'm not trying to say that it's 100% evil, but like I mentioned before, it's not at the point where it can replace people that are trained in the interpretation. And my concern is that you're setting yourself up for misinformation if you're using a company that relies heavily on AI for interpreting those results. I think another red flag is the promise to tell you what your doctor is quote unquote hiding from you. So let's be real. A lot of us with chronic illness have horror stories about medical professionals that don't listen to us. It's a flawed system, and it's one that has a history of racism, sexism, ableism. I'm a disabled adult who's working in a field that started with eugenics. So I get that there are some concerns about the medical establishment. And I'm not saying that you should trust every single medical provider you have implicitly. But what I can tell you is that we don't go into this to prevent people from getting answers. I hate when I cannot find an answer for a patient with testing. If you're coming to see a geneticist or genetic counselor, it's because either you have a problem or you're wanting to prevent a problem. We're not trying to hide information from you. It's in all of our best interest to run appropriate tests and to look for a diagnosis. So if we tell you that, to the best of our current understanding, with the understanding that genetics changes over time, that something isn't genetic or a test isn't appropriate, it's because we don't want to waste your time or money. We don't have a one-stop shop genetic test that will tell you everything. Even the most broad test, whole genome sequencing, which we'll talk about, is still phenotype or symptom-based. So this means the lab is looking at your symptoms and interpreting results through that lens. It's not a crystal ball for practical, logistical, and ethical reasons. Final red flag is pushing testing for hypermobile EDS. Right now, hypermobile EDS does not have a gene associated with it. I know that there are some what we call candidate genes being tossed around. So research that maybe, suggests that this could potentially be a link, but there's not enough data to have testing for those genes worthwhile right now. They're not clinically offered. But there are many researchers who are working on this issue. And once we have a genetic cause identified, I think professionals were going to be shouting it from the rooftops. But as at this point in time, genetic testing cannot be used to diagnose hypermobile EDS. It's a clinical diagnosis. And we will talk more about that in a few slides. So again, I'm not aware of many other labs outside of what I've mentioned that have results that I would say are clinically accurate, at least not for aortopathies. And I personally have not had a patient bring me a direct-to-consumer test that was clinically accurate yet. Doesn't mean that it doesn't happen, but for the same cost or less, you can get clinically accurate testing from multiple places. So let's talk about what testing we can use to diagnose aortopathies and Stickler. There are a lot of different types of genetic tests, but for these conditions, we're talking about panels, whole exome sequencing, and whole genome sequencing. A panel is a collection of genes that all cause the same type of condition. So we use it when we know a diagnosis. For example, you have a diagnosis of an aneurysm, so then we look at what we call the TAD panel, the thoracic aortic aneurysm dissection panel. Positives, it's very focused. Insurance usually doesn't have a problem covering it. It's going to identify most cases that can be identified with current testing, and it's fairly inexpensive. Downsides, panels only get updated about every 5 years or so. So any new genes that have been discovered since the panel was created aren't going to be included. And different labs can choose different genes to test. So for an example, with TAD panels, One lab offers 28 genes, covers all 6 types of Loeys-Dietz. Another lab offers 33 genes, but only covers types 1 through 5 of Loeys-Dietz. There's not one that I found that really covers everything. Whole exome sequencing, or WES, is a more broad test. So our exome is the protein coding portion of our genetic information. We use this when there are symptoms that would require multiple panels, when there's no specific diagnosis or no great panel, when there's autism or intellectual disability or global developmental delay. And it is a symptom-driven test. So again, we're giving the lab all the symptoms that a patient has. They're looking through all of the exome for any changes that may explain any of the symptoms listed. Positives, it's a broad test that can pick up everything a panel does and then some. And it can also be reanalyzed once for free. There's one lab that reanalyzes annually for life for free too. And it can be run as a duo or a trio. So typically we get samples from one or both parents if they're available. And that helps cut down on the rate of uncertain results. Negatives, there's a higher chance of an unexpected finding, and insurance may be less likely to cover it, and it's a more expensive test. Unexpected findings are not a deal breaker for everybody. Some people would just prefer to keep a test very focused. And by unexpected findings, I mean, there could be a diagnosis that's only kind of tangentially related to the symptoms. Or if you're testing both parents, you could find that there's non-paternity or non-paternity. So dad isn't dad or mom isn't mom. And you can find consanguinity, so parents being related by blood. So personally, I'm offering aortopathy patients a choice between whole exome and a panel. One, because I don't think there's a perfect panel, and two, because of the chance for the test to be reanalyzed in the future if we don't get an answer. But different genetic counselors and geneticists approach, testing differently. And then whole genome sequencing is the largest test available. So that looks at chromosomal changes, extra missing pieces of the chromosome, plus all the exome, plus introns, which are the spaces in between genes. And like with exome, we use this when there's not one panel to use, or there's autism or intellectual disability. Again, it's most efficient because it's kind of a one-stop shop, and it can be reanalyzed once for free, helps drive research into new genes. But this one, private insurance, I find is the least likely to cover. Some of them still consider it to be experimental because we're still learning a lot about intronic involvement. So there may be more likely to get information on reanalysis, a few years in the future than right now. Okay, so who needs testing? This graphic, you want to screenshot it, and the one on the next slide, come from the 2024 AHA guideline, Cardiovascular Management of Aortopathy in Children, which was written in part by some of the doctors on the Foundation's Professional Advisory Board. So this graphic is a list of symptoms that we can find in syndromic aortic conditions, so like Marfan, Loeys-Dietz, VEDS. Some of these symptoms are more concerning for a genetic basis than others. And I'm saying this as a discussion for people without a diagnosed family member, because if you have a family member who's already been diagnosed genetically, anybody in the family can just be screened for that same variant. But if you or your child have an aneurysm or dissection, even without other symptoms, genetic testing is something to consider. Lens dislocation, that's another symptom where I would suggest genetic testing on its own. Same with hollow organ rupture. These are things that are very rarely seen in the general population. So if you have them, it's much more likely to have a genetic cause. For some of the other symptoms, though, they're really only concerning when they're seen in conjunction with other things. So for example, take changes to the chest, like pectus excavatum, where the chest dips in, or pectus carinatum, where the chest bows out. We can see these as isolated findings, either polygenic in nature, like we talked about before, or, I mean, they can be passed parent to child through a family, but where they're isolated and there aren't other symptoms. We haven't identified what genes cause isolated pectus anomalies yet. Or we can see them in Marfan syndrome and these related conditions. But if we're seeing them in Marfan, Loeys disease, etc., we're going to see other symptoms too. Someone isn't going to have Marfan and only have pectus excavatum and nothing else. When we're making a risk assessment in genetics, we're trying to determine how likely the problem is to be something that we can find an answer to with genetic testing. So, in the lower right, it talks about hypermobility. Being hypermobile is very common. So in the absence of other syndromic features, testing isn't going to be useful. But again, if it's in conjunction with other things, then testing could be appropriate. This is a really good flow chart from that same paper that further outlines who should be offered genetic testing. And the BAV stands for bicuspid aortic valve. And you can see that they've put them into two different categories there. If the patient has bicuspid aortic valve or no bicuspid aortic valve. Now for Stickler, some of the symptoms that would be concerning include a cleft palate, broad or flat nasal bridge, small jaw or recessed jaw, hemyopia, meaning significant nearsightedness. Retinal abnormalities include retinal detachment, sensory neural hearing loss, and then osteoarticular manifestations, so joint pain, early childhood, early onset degenerative joint disease. But again, we're looking to have multiple concerns. So having joint pain in childhood alone and nothing else on this list is not going to be enough to be worried about Stickler. Sensory neural hearing loss is an indicator for genetic testing on its own, but it could be a lot of different things. It's in combination with other symptoms where we think about Stickler syndrome. So who needs to see a geneticist or a genetic professional? Let's talk about genetic counselors versus geneticists. Geneticist has an MD, so they have a doctorate. They've gone to med school, they've done their residency fellowship. A genetic counselor has a master's degree. We have training in genetic conditions, in interpreting genetic testing results, and counseling. We cannot do physical exams. So an MD or a nurse practitioner is needed to do a physical exam. We also can't interpret other types of tests. So I couldn't order an echocardiogram and interpret it on my own, but I can interpret genetic testing. So you don't necessarily need to see a geneticist in order to get a diagnosis of Marfan or a related condition. In my hospital, I see patients concerned for these two conditions in one of two ways. So first, we have a pediatric multidisciplinary clinic where our fantastic cardiologist has been trained in the physical exam. So children come in, they get an echocardiogram, she does a physical exam, goes over their echo results, and then if there's enough concern for genetic testing, the patient will then see me right after that. For children who have had a recent echocardiogram or for adults, then they just come and see me for genetic testing. Our hospital has adult aortopathy patients, but they do that after they have a diagnosis. So it's much faster to go this route than it is to wait and see a geneticist. As I'm sure many of you know, there's a shortage of geneticists. And so in a lot of places, it's a year, 2 years or more wait list to see a geneticist. If symptoms, though, are nonspecific, it can be really worth the wait to see a geneticist for a complete physical exam. Or you could see a genetic counselor for initial testing, say a panel, and then ask to see a geneticist, if that's negative, to look at maybe doing whole exome or whole genome sequencing. I will say that an echocardiogram is an important part of this process. So if you're going to see a genetic counselor on their own, then I would talk to your PCP about ordering an echocardiogram ahead of time so that the genetic counselor has the results of that echocardiogram to help justify testing with insurance and to use as part of, the overall risk assessment. If you're going to go to a multidisciplinary clinic, then they'll probably prefer to do the echocardiogram there, but that's a question you can ask, when you schedule. So hypermobile EDS. Again, you may want to screenshot this slide and the next one. That's fine with me. Hypermobile EDS is a diagnosis of exclusion. And so a question I see a lot is, don't you need genetic testing in order to exclude the other conditions? And the answer to that is no. In the absence of other symptoms, you don't need genetic testing. Now, I wish that we could offer testing for everybody that wanted it, but there's limited resources and a high demand, which plays into this as well. If you have hypermobility, dislocations, subluxations, stretchy skin, POTS, MCAS, symptoms of hypermobile EDS, then a PCP can actually do the diagnosis for you. Now, I want to make it clear that just because we don't have a gene for these different symptoms and for hypermobile EDS is not to downplay the condition, right? These symptoms can be debilitating, and I'm not trying to say that it's not serious just because genetic testing isn't necessary at this time. Most genetics clinics are not accepting referrals for hypermobile EDS because there's not genetic testing available and because the demand is high, but the number of providers is low. Our clinic, our genetics clinic, gets probably 3 to 5 referrals for hypermobile EDS a day, and I see about 20 patients a week. So I could see nothing but hypermobile EDS, but I'm the only cardio GC, so I have to see everything cardiac. And so this is why, in terms of like getting into a genetics clinic, it can be very hard to do, but again, it's not required. If I were concerned about hypermobile EDS, I would ask my PCP to order an echocardiogram that includes the aorta. The only way to know you have aortic enlargement is to check for it. And then look at, do we have the symptoms that we talked about earlier that are heavily associated with aortopathies? If so, then I would see a genetics professional. If you have a family history, so a first or second degree relative that is concerning for those things, I would want to go see a genetics professional, or a multidisciplinary clinic. First or second degree relatives, meaning children, your siblings, parents, aunts, uncles, and grandparents. But if your family history is clear, if your aorta is normal, and your symptoms are only ones that fit with hypermobile EDS, then your PCP can do the physical exam. There's no need to wait, months or years for these appointments to get the diagnosis, to get started on physical therapy or other treatment when your PCP can do it. It's also important to note that per the 2023 guidelines, a person must be post-pubertal, so finished with puberty, or 18 years old, whichever comes first, in order to get a hypermobile EDS diagnosis. So they are no longer doing the diagnosis for kids. Now, how to find a provider. The Marfan Foundation has a clinic directory right on their main website, so that is a great place to look. You can go to findageneticcounselor.nsgc.org. NSGC is the National Society for Genetic Counselors. And on that website, you can search by state, you can search by specialty, you can search by telehealth, and find whoever is licensed in your state to provide care. Could be at a hospital, could be a private practice. The cardiogenomic testing website is another listing of genetic counselors and geneticists who provide genetic care specifically related to cardiovascular issues. Genome Medical, Informed DNA, and the Genetic Support Foundation are all private organizations that take insurance, and they do exclusively telehealth. So I do know the Genetic Support Foundation may require a referral depending on your state but I do not believe that the other two companies require referrals. GeneXure does not take insurance. So it's totally private pay, which also means that the results are not automatically going into your medical record. I don't know if you would still have to report those results, like in terms of Gina, because they're still a licensed company. So if you're looking at going through them to try to avoid having to report things, I would just like consult a lawyer for the intricacies of Gina. I don't have ties to any of these companies. They're just ones that I'm aware of. Although I'm listed in some of the directories like the NSGC one. So closing thoughts, an accurate referral matters. So if you're getting referred for symptoms, make sure that those symptoms are listed in the referral and not just hypermobility. I've seen multiple referrals where the doctor just put hypermobility, and then when I'm looking on the chart, I'm seeing that they have an aneurysm or their parent had a dissection. So you want to make sure that your referring provider is being accurate so that you can get your case triaged and scheduled as quickly as possible. Advocate for what you need. If you're concerned about hypermobile EDS, your PCP may not know that they can diagnose it. And so you may have to advocate for that. Or your provider may not know, when to make a referral for some of these other conditions. And then ask questions. So if I'm sitting here saying that the expertise matters for result interpretation, your provider should be explaining to you why they're suggesting a test or not suggesting a test, or why an uncertain variant is not concerning and not just telling you that it's not. So in as far as we have the explanations, we owe them to you to give them, and you shouldn't feel shy asking for those. And now I'm good for questions, and I'll stop sharing.
Maya, thank you so much for presenting on such an important topic for our community. We do have a few questions submitted by our audience members, and we'll go through those now. Okay, is it appropriate to pursue genetic testing before the robust cardiac testing? This feels much less invasive and costly, especially for someone without any cardiac symptoms.
You can, if there are, multiple syndromic symptoms, but a negative genetic test still doesn't mean that you don't have cardiac issues. And that so when we're talking about testing for syndromic aortopathies, we can find an answer with genetic testing maybe 70 to 80% of the time. When we're looking at non-syndromic aortic conditions, we're finding an answer. I think it's being liberal to say 20% of the time. So, if your dad had a dissection and you want genetic testing to see if you're at risk, even if your test is negative, we don't know what his would have been. So the only way to know if something's going on is to have the cardiac imaging done. And if we have an uncertain result or a negative result, knowing the status of your aorta helps us to be able to interpret that and come up with, what your risk is, even if you have a negative result.
That makes sense. Thank you. This person writes, I was extensively tested about 4 years ago for Marfan and other connective tissue disorders. Nothing was flagged for me, but I do have a genetic aortic aneurysm. I also could not be diagnosed for anything in particular through the markers they were looking for. Are there any new genes that are being tested at this point that would be good to look into?
I would look and make sure that your test covered the 6 types of Loeys Dietz. And if it did, then I would say to wait. There aren't any in the past couple years that I'm aware of. And in ClinGen, which is an international working group where we kind of figure out what genes are related to what conditions, I'm in the working group for aortopathies. And we're looking at genes that we already know about, and then from there we'll go on to looking at newer genes. So I think we're still a few years out from having more.
Okay. Do you ever recommend delaying testing until after health insurance, disability insurance, life insurance is in place in case results are positive?
Yeah, I think that it's when I'm doing counseling for asymptomatic people, it's a conversation we have all the time. And if you are getting testing and you already have an aneurysm, that's going to impact your life insurance more than the genetic test result is. But if we're talking about, say, testing your kids, then if life insurance is something that's important to you, then yeah, then I would look into getting that set up first, and then doing the testing. It just, for some people, it's important, other people, it's not.
Understood. Great point. Thank you. Does direct-to-consumer testing allow for repeat evaluation within a few years once more data and research are available, like some of the other testing that you mentioned?
I think it's going to depend on the company. Um, I think most of them, it's like a one and done, although you can pay to like keep hold of your data. Um, there's one I saw recently that it sounds like they may allow for a reanalysis, but you'd need to check on each one.
Okay. So do your homework. Great.
Yep.
I have classic Marfan symptoms, dislocated lenses, aortic aneurysm, scoliosis, and skeletal issues. I'm already 61, but have never had genetic testing as it was never available. Would it be practical to do at this point?
Yeah, it's easy. You don't have to have a blood draw. We can do, we call it buccal swab. It's like a mouth swab. And just like with the direct to consumer, we can do a telehealth appointment and send, we being whoever your provider is, and send it to your house. Um, will it change anything for you? No. If you have your diagnosis, um, it'll just give you the genetic cause, but it would allow for testing, for extended family members so they know whether or not they have it, because um, sometimes symptoms are mild and so people get missed. If you have kids, grandkids that want to get tested, or use reproductive technology, things like that, having that test result is useful for those things.
Great. And you mentioned the swab versus the blood draw. Is there, as a genetic counselor, is there a preference one way or the other for what patients get?
No, they're both equally as good. Um, in a very small percentage of people will get back a change that impacts something called splicing. And if it's uncertain, then we may do like follow-up analysis that requires blood. But we can always do that once the results come in if it's necessary. I just tell people to pick whichever their preference is.
Okay. I have been diagnosed with LDS and have gone through the echocardiogram. Do I need a genetic counselor to advocate for further testing?
If you haven't had genetic testing, then I would talk to your doctor about that. So there are clinics where there are cardiologists who order the genetic testing and interpret that, and you wouldn't necessarily need to see a genetic counselor. And then there are other clinics that are set up where they would have you see a genetic counselor or a geneticist. But genetic testing can be helpful, especially with Loeys Dietz, because we have gene-specific management guidelines. And so, each type 1 is one gene, type 2 is another. So knowing which gene it is does impact, when they would do surgery or some of the other management monitoring that's done.
Okay. Does whole exome sequencing sometimes include intronic variants?
Yeah, so, and we can get a little bit of intronic variants with panels too, kind of on the edge, but it's not going to cover the deep intronic variants. That's only going to get picked up with whole genome sequencing.
Okay. This person says they've seen some direct-to-consumer reports report on pathogenicity, for variants reported. How do you counsel people on what pathogenicity for this type of testing means?
I look into the variant in different places. ClinVar being, one of them, but we suggest clinical correlation. And so we redo the test clinically to make sure that it still shows up when we're using a certified lab with the correct technology.
Okay, great. And I think that is everything. We did have someone ask about the upcoming webinar related to variants of unknown significance. That will happen in March. We haven't posted all of the details about that yet, but we will get there. Many thanks to those who shared their questions and to Maya for so thoroughly addressing them. We appreciate that so much. Let me just share my screen again for a moment to wrap things up. Okay. Our webinar tonight is the first in a three-part series on genetic testing. Please join us again on February 25th for a discussion with Dr. Peter Byers on how to read a genetic testing report. You can register for this webinar by scanning the QR code on your screen. We'll also be communicating information about the webinar by email and our social media channels, and we hope to see you next month. Maya, again, thank you so much. We appreciate you. This was such a wonderful opportunity for our community.
Thank you.
And before you go, please take a moment to share your feedback on this webinar by visiting marfan.org/survey or scanning the QR code on your screen. I'll give you just a second to grab that info. This helps us to offer you the best possible programming, so please take a moment to share your thoughts. Thank you so much for joining us today. Take care.
Thanks, Maya. Thanks, everyone. Good night.
Good night.